Hi everyone, so we're going to get started. This is 201. My name is Cineva Hackman and I'm the program coordinator for the SHIP Technical Assistance Team with the National Rural Health Resource Center. I'd like to welcome you all to today's SHIP TA webinar on care coordination activities in SHIP. We're glad you could take the time to be here with us today. Before we get started, I'm just going to go over a few housekeeping details. So when you call in, your phone line will be muted. To unmute or remute your individual line, press *2. Once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can always communicate via the chat box at any time, which is located on the left-hand side of the screen. We will go over any questions at the end of the presentation. And then below the chat box is the file share box, which will contain today's copy of the webinar slides. When you click on the name of the file in the file share box, you can then click on the download button to download that file directly to your computer. And then these materials will also be available on the SHIP TA website. Throughout certain times of the webinar, we will have the opportunity for you all to provide us with feedback through a quick polling process. Whenever you see the gray dialog pop up on the screen with a question, please select the most appropriate answer. And today's webinar will be recorded, and a link to the recording will be provided when it is uploaded to our website. Before I send it over to Kate with the National Rural Health Resource Center for introductions, I have a pre-polling question for you all to answer.
Great, thank you, Cineva. Again, this is Kate Stenham, and I'm a program manager here at the National Rural Health Resource Center. If everyone could take just a minute and fill out that poll that Cineva has popped up onto the screen, that would be great. It gives us some feedback to just kind of gauge where everybody's at with this particular topic. And while you're filling that out, I'm just going to go ahead and welcome all of you, and thank you so much for joining us today for the SHIP webinar on the topic of care coordination. So looking back, we really value your feedback, and I know we just sent out the 2019 SHIP TA assessment, so I just want to take a second here to encourage all of you to take a brief 5 minutes and fill that out. That was sent out earlier today by myself. That will be open for 2 weeks, and we're really looking forward to everybody's feedback on that and how we can improve the SHIP program and the technical assistance that's provided through the SHIP program. So some feedback from the SHIP coordinators and State Office of Rural Health Directors has been pretty consistent with asking for new and innovative SHIP ideas and new and innovative SHIP activities, as well as wanting to hear a lot about some state best practices. So we are doing the topic of care coordination today because care coordination activities are an allowable investment activity for SHIP. They fall under the category of accountable care organization and shared savings on the allowable investment SHIP purchasing menu. And care coordination, as you all know, the activities can really improve the quality of care by coordinating care across the continuum. And when care is coordinated, it can really help to maximize the value of services delivered to patients. So I'm not going to go into any more depth on that background, and with that being said, we are so excited to have the SHIP Federal Office of Rural Health Policy Project Officer, Soleil Berry, on the line with us to present today, as well as grantees from South Dakota and Washington, and they're all going to be presenting on this topic today. I'm going to now turn it over to Soleil for a program and grantee overview to get us kicked off. And just as a reminder, everyone is muted so that we can reduce background noise. So for the speakers, it is *2 to unmute your line. And Soleil, we can't hear you yet if you're speaking. *2 to unmute your line. No, we can't hear you yet. Yep, *2.
Hello, can you hear me now?
Yeah, we can hear you. Great.
Okay. Thank you, everyone, and apologies that with technology, sometimes you think you get it and then you don't. But with that being said, thank you for joining us for this webinar. This is something that this particular topic is very, very important and very close to my heart, because actually I used to be the coordinator for this program, which was called the Rural Health Care Coordination Network Partnership Program, which will just shorten to say care coordination. So before I joined SHIP, I was actually a program coordinator, and I had great grantees in that overall in the program, 8 of them. And I'm going to just briefly kind of highlight the program, what it was about, and send it over to the 2 speakers, because they really have 2 unique programs and are able to talk really about what worked well for them. In terms of just to give you an overview, the Care Coordination Program was authorized under the 338 Public Health Act, and really it was focused on making sure rural health networks can promote, plan, and implement a grant to achieve efficiency, expand access to care, improve quality of health care, and strengthen the rural health system as a whole. Within that, our program goals were to support the development or expansion of formal rural health networks, focused on care coordination activities, targeting our 3 chronic conditions, which were type 2 diabetes, congestive heart failure, and COPD. Our grantees had an option of focusing on all 3 or 1. And overall, we actually had 8 grantees, which you see across the map. Each of these programs in the 3 years that we had this really implemented evidence-based care coordination programs that suited their area. So even though they were all doing care coordination, that looks a little different across the board. Next slide. This is just to give you an overview of the different programs that we had, the different grantees that we had toward at the end. As you can see, not only were they different in states, but even in terms of their core areas of expertise. The 2 highlighted are the programs that we're talking about, who are very specific hospital-based programming that makes sense for the SHIP program, but this is not to say that the other grantees also didn't bring a lot to the table. If you are interested in learning more about these programs individually, because we did have everything from ACOs to rural health hospitals, some focus on telehealth, and some were using CHWs, as you can see from this chart. At the end, at our resource slide, I will be going over where you can find more information about these grantees individually and some of the outcomes that they have. With that being said, I do want to turn it over to our speakers. Again, all my grantees were great at what they did, and I'm very proud to present these 2 because they had some very clear outcomes and very distinct programs that really I think the SHIP coordinators will benefit from. Thank you.
And Jack, we can't hear you yet. Star 2 to unmute your line.
Okay, I just unmuted. Can you hear me now?
We sure can. Thank you.
Excellent. And thank you so much, Soleil, for the introduction, and also thank you for the opportunity to work with you. Soleil was our program manager, and it was wonderful to be able to work with her, and enjoyed having her out to visit in Washington. My name is Jack Davies. I'm the director of the Northwest Rural Health Network, and I'm going to see, I can control my own slides. I just want to start out briefly by acknowledging the support that we received both from HRSA for this grant and also a group called the Empire Health Foundation, a regional philanthropy, and I'm going to talk about it a little bit more in a moment. Let me just also describe a little bit about who we are. We're a horizontal network, a nonprofit multi-county of rural health systems in eastern Washington. And what we do together is look at how we can share resources, identify operational efficiencies, and overall just really work together to improve both services and health status in the communities that our members serve. We now have 15 members across 10 counties, all located sort of in the eastern third of Washington state. The grant that Soleil mentioned, as she indicated, was really focused on improving the coordination of care for vulnerable populations, and we were looking particularly at seniors and low-income and minority populations with those chronic conditions that she mentioned. Although we have 15 members for this grant, we focused on 4 particular rural health systems that were located in 3 counties here in eastern Washington. And what we did was work with a large Medicaid managed care organization called Molina to implement a very specific program called the Health Home Program. It's an intensive care coordination program, very structured. It's targeting very high-risk, high-need individuals on the Medicaid plan and has a lot of very specific elements, including regular meetings with a care coordinator, home visits, and the use of a data registry to capture information and track progress. This was a public and private partnership, and we were one of a couple of recipients of this grant that entered into this approach. As I said, we had 4 independent, non-competing health systems in 3 counties. One thing they did have in common was a common referral pattern to the urban tertiary care centers in Spokane. We also had our network serving as sort of the overall structure for coordination and some of the evaluation. I mentioned Molina. They are the largest Medicaid managed care organization in the region, and they already had in place this Health Home Program, and they're not the only one. It's under a requirement under the Medicaid contractors in Washington to operate this program. But one of the good things about it is that it includes a payment model for reimbursing care coordinators, so that was a piece that was baked in from the beginning. The third partner, the Empire Health Foundation, they're a regional philanthropy here in the northeast corner of Washington state. They have a strong interest in healthy aging for people who live in rural communities, and they also contributed some funding and helped out in some other ways, helped us in some of the outreach in our region. And then, of course, our partner being HRSA itself, that helped us not only with the funding, but also connecting with our peers around the country and really promoting this concept of collaboration with philanthropies. Now, from a need perspective, we wanted to do this because the residents of our communities are probably very similar to what many of you experience. Older and sicker individuals, low-income individuals living in these very, very small remote towns. Another piece, of course, is that these towns have limited local resources, often a shortage of housing, certainly a problem with transportation. And in 3 of the 4 communities, a lack of some of the more typical social services, aging and long-term care services, for example, or some difficulties being able to access behavioral health, some of the other sort of safety net features that can often help with rural organizations. 3 of those 4 communities also had limited care coordination capacity and experience, so they were really starting from ground zero. The 4th had both more capacity and also some experience in care coordination going into this. All of these systems consisted of both critical access hospitals and their associated rural health clinics, but they did vary quite a bit in size, and both of the facilities and their communities, and that of course affects their ability to hire and then also their overall capacity. Briefly, what we did in this program was with some funding and with some centralized support. At each of these 4 facilities, they worked at recruiting and hiring care coordinators. Those individuals were trained in this Health Home model. As I said, it was very specific, and it included a fair amount of training to get up to speed, and also the use of required a technology platform that I mentioned that was used as sort of an extension of the electronic health record to capture a lot of the data, and also they brought into this data from other sources, including claims and other state data systems. So those care coordinators actually had a lot of information on the individuals they were supporting. There was some training for primary care teams so that they would understand the role of these care coordinators. And then the program had to be promoted. It was voluntary for the patients, and there was a lot of outreach and recruitment efforts, and that actually turned out to be one of the biggest challenges was reaching some of these patients and encouraging them to enroll. For those that did enroll, there was a process that including a fairly thorough intake assessment, a creation of a health action plan that was driven by some of their own health and also some of their social determinant of health type needs. They then got regular contact with the care coordinator, including visits at home, and they got assistance getting connected to services they might need, and not just health-related services, but also community services. Then on an ongoing basis, the care coordinators had regular contact with Medicaid Managed Care Organization, and then they served as the liaison with the care team. I do want to just say briefly that one challenge when you talk about care coordination is that everybody uses the term a little bit differently. And in this regard, sometimes care coordination is thought of as being very specific to clinical care coordination, what happens between primary care and specialists, what happens upon discharge from the hospital, and so on. In this scenario that we've been doing here in Washington, it included those pieces, but also this broader outreach to get people connected to some of those social determinants of health, to address those social determinants of health needs. And that led to some of the challenges I'm going to describe here in a moment. But we were successful at getting up the program implemented in all 4 systems. Pragmatically, the 3 systems that had limited prior experience struggled a bit, in part because they were a bit more challenged in getting it integrated into their primary care program. We were able to, through lessons learned on this project, influence both Molina and state policymakers on how to adapt this health home program for rural providers. So, for example, the program initially required that those care coordinators only be nurses or licensed social workers. And some of the smaller communities had real difficulty recruiting for those kinds of positions. And with our input, that policy was expanded to allow medical assistants with training to be used as care coordinators. We were able to help the facilities get new capacity. So some new staff were hired and then a lot of training, so there was much more better knowledge of care coordination after the end of this than at the beginning. And then this whole idea of a sustainable model. I know that one of the big challenges with care coordination programs is that they're often started with grants, but they find it difficult to keep going. And this helped us learn how to piece together funding, including those Medicaid managed care payments that I described for doing this kind of work. So what we learned in this, and a couple of things, as I say, we succeeded at a lot of what we wanted to do, but we also identified some of the challenges here, and 3 of the 4 systems went ahead and added these care coordination responsibilities to nursing responsibilities. So they hired nurses, or they shifted duties around for existing nurses so they could take on this care coordination work. The 4th facility brought in a social worker, and that individual was dedicated completely to doing the care coordination activities. Relying on the nursing staff presented a couple of challenges. First, pragmatically, those individuals, trained clinical nurses, did not have experience in dealing with a lot of those social determinant issues and dealing directly with people and trying to address those issues. And so they found this to be extra challenging. And that included things like doing home visits. That was something that made the nurses who had not had that prior type of home care experience very uncomfortable, particularly considering the very remote locations that many of these people live in. The 4th health system that had a social worker, she had a much stronger background in this and was able to dive right in. And then also pragmatically, in these very small health systems with limited staff, sometimes that care coordination did take a back seat just to nursing. And when you're down on staff in the ED and you have a nurse available, that nurse generally has to step in. And so that was definitely a challenge. The other piece that was, I think, a factor in success and better results in one system over the others is how well that position was integrated into the primary care team. It really makes a difference on how much interaction there is, on how much acceptance there is in the primary care team of this care coordinator role. And so that was something that we felt really would make a major difference and would really be considered a best practice. And sort of the bottom line, I put a quote there from one of the nursing directors, and this I've sort of called out the differences between care coordination programs, and I think some of these nursing directors went in with the vision of this care coordination as being more at the clinical end of that spectrum that I described earlier, when the reality is, as she commented later, you can't start addressing a person's health needs until you've addressed their basic needs like housing and with water and electricity. And that's, I think, some of the challenges that some of these smaller health systems ran into. Also, one other just final lesson I wanted to really emphasize is that these care coordination programs cannot succeed in isolation. You have to be able to get people connected to home health agencies. You have to be able to get them connected to better housing if they don't have housing, or improvements, access to places to store healthy food, access to healthy food, etc. And some of these very small communities, they just don't have these services. And the care coordinators became really frustrated because they knew that the patients they were trying to work with had these problems, and there were no local solutions for them. They couldn't refer them down to a housing agency or a transportation agency or so on. So I think that as a broader lesson, and this is part of the overall practice transformation piece, that for successful care coordination, particularly in rural communities, health systems have to look outside the clinic and figure out who else they can partner with to address those social service needs. And it may be that most recently, I was at a meeting a few weeks ago with several of these sites that participated in this project, and they're recognizing that rather than trying to build capacity internally, they need to find social service agencies and, if necessary, attract them into the community. And maybe those social service agencies provide this more social determinant of health type care coordination. But those activities need to be integrated into primary care. And the analogy is the way now we're all looking at how we integrate behavioral health into primary care. It may, in fact, be a behavioral health agency that's providing the staff and doing the work, but they're working in close partnership with the primary care staff. And I think that some care coordination models may need to go in this direction as well. So it's a very quick rundown over what we did. And with that, I'll turn it back over to Mary.
Just a reminder, *2 to unmute your line, Marnie.
Okay, can you hear me now?
Yep, we can hear you.
All right. I'll just start out with thank you for having me speak, and we enjoyed working with Soleil and our care coordination project here in South Dakota. We received our grant funds in September 2015 and concluded the grant last fall in 2018. The Completing the Circle project was a collaborative effort of 3 healthcare providers in rural South Dakota. I work at Avera St. Mary's Hospital in Pierre, which is the capital of the state and in the center of the state. Avera St. Mary's became the lead partner, and then we worked along with Vilas Pharmacy, which is 13 locations throughout central South Dakota, a small pharmacy, privately owned. And then we also collaborated with South Dakota Urban Indian Health, which is an urban Indian health clinic funded through IHS, or Indian Health Services. So this is the flyer, the pamphlet that we used for the program. I guess I'm just going to backtrack a little bit and just recognize that Avera St. Mary's is one of 6 regional PPS facilities within the Avera Health system. You'll see on the next slide that Avera Health, our central location flagship, is in the southeastern corner here where Sioux Falls is in Minnehaha County. But our grant covered central South Dakota, and on this slide you can see the 13 counties that were involved with the program. St. Mary's is about a 50-bed rural facility, and it covers a large geographic area, about a 100-mile radius is what we say, and we are the westernmost region of Avera Health. We do offer a full range of services from primary care to specialty services, outpatient, inpatient. Last fall we opened a cancer center. We now have a fixed wing located in Pierre, and also have home health and hospice services. Throughout the grant, this project, we decided to focus on type 2 diabetic patients, and the care would be centered at 6 different clinic locations, and that we were just going to be able to coordinate the care for these type 2 diabetics who needed assistance managing their disease. We really started the project focused on the Native American population. 11 of these 13 counties are extremely rural or designated as frontier by the U.S. Census Bureau. Frontier means less than 7 people per square mile, so it's some pretty remote area that we cover territory there. The overall goal of the project was to give this individualized care to our type 2 diabetic patients, and we wanted to use the coordinated care services with a nurse, a coordinated care specialist, and a social worker on the team. And then also leveraging our Avera's telehealth technology and the Avera Now platform. Patients could get improved access to care for their diabetic education through use of the telehealth platform. This project utilized the evidence-based patient-centered medical home model. And just a couple more points on our demographics I wanted to bring up was that the total population of the service area is approximately 54,000 people. Sometimes access to health care for these folks can be 60 miles one way. So there are some IHS facilities in those locations, but tend to be underfunded and over capacity. We, in our various clinics, provide these Native Americans with, just want to surround them with care so that they didn't have to travel so far. You know, barriers to their care is travel, it's access to healthy food, it's ability to go to an exercise facility, some of those things that we in more urban areas really take for granted. A little bit about the Native American population is that 18% of that service population was Native American. 10% of the population in these 13 counties is below the federal poverty level. And also a large portion of this population was uninsured. About 16.6% of the target service population is uninsured. So that's a lot about the demographics, with a lot of statistics kind of to demonstrate the need and to tell about our services. These are the strategies that we used within the care coordination project itself, or completing the circle is what we called it. To be able to enroll patients, they had to meet several elements, 3 or more diagnoses requiring treatment, 4 or more prescription medications, severe illness, chronic illness, behavioral health diagnosis, physician referral. That was one of the primary ways the physician would identify the patient as someone who needed help managing their type 2 diabetes and refer them into the coordinated care team, who would then enroll them in this specific project. We were looking at this project in at emergency room utilization and hospital admissions. The enrollee's physician had to approve of their admission to the coordinated care and the Completing the Circle program, and the patient had to consent to be a part of the program. Once again, the support staff or the team was the primary care physician. Then we had our RN case manager, the coordinated care specialist, the social worker, and then we utilized the certified diabetic educator. And this certified diabetic educator, after the coordinated care team identified the patient and enrolled the patient, would do 3 initial education sessions with the enrollee. The CDE would go and meet with the patient in their hometown. They do a local grocery store tour, just being able to see what foods they typically would buy, and then she could help educate them on some healthier choices in their own local grocery store. She also would do a cooking kitchen with the patient and the family. We really encouraged the family to participate if possible, noting that we could really impact the health of not only the enrollee but the entire family. Additional program components were that there would be a monthly touch base with the primary care with the coordinated care team, that clinical data was being monitored by the care specialist, and then the coordinated care team would help make sure the compliance with their appointments with their primary care provider. So some of our final outcomes, we really did have some really nice outcomes from this program. We were able to demonstrate that surrounding the patient with these supportive resources really did contribute to improved health and reduced utilization of services. We did have patients, enrollees who used the Avera Now platform. We did approximately 30 visits. This was above the initial 3 sessions, the sessions with the CDE that every patient got. If they needed additional time with our, we had an advanced practice diabetic specialist who would be able to do appointments with them through Avera Now, which is a telehealth platform. So utilization statistics in our final outcomes were that we reduced inpatient admissions by 50% within our enrollees, and we also reduced ED visits by 46%. Not we, the individual did, with a lot of hard work and education. Clinical outcomes that were demonstrated throughout this project were a 2-point decrease in hemoglobin A1C values, 34% improvement in dilated eye exams, and 65% improvement in diabetic foot exams. Those are some of the highlights. We did really monitor a number of patient outcome indicators from pre-enrollment then to the end of the program. We looked at BMI and reducing BMI. We looked at blood pressure. We looked at microalbumin screening, colorectal cancer screening, breast cancer screening, PHQ-9, which is the suicide depression screen, or depression screening. And we held advanced directive discussions with these enrollees, and then also monitored whether they had the inpatient admission or ER visits. We improved in nearly every one of those metrics by a fair amount or remained neutral, and there was only one metric that we had a decline from pre-value, and that was in the microalbumin screening. My next slide. So that's kind of the conclusion of my program. I would just say that it was a model of care that we found very successful, and have determined that we would roll out throughout all of our coordinated care programs throughout the Avera Health system. So it was a model of care that could easily be rolled into our coordinated care programs that were in existence, and we look to continue providing these type of supportive services to patients throughout the system. So thank you, and if you have any questions, let me know.
Thank you so much, Marnie. Now we're going to turn things back over to Slay.
Thank you, Marnie. And Jack, I knew that when we decided to do this webinar that both programs are really strong candidates because they really are so unique, and but they're strong in their own ways. And you see that not just in the outcomes, but also how they've been able to really think about care coordination, again, in their respective communities and having to deal with the challenges. This is a very small slice of how incredible these programs are. And one of the things I wanted to highlight, next slide please, is some of the care coordination resources. These tiles are actually hyperlinked. So if you wanted to know a little bit more about the actual grantees in the care coordination program, that we do have a directory as well as a source book. The source book has not been out yet, but it will be. We will send that link when it does. But the directory gives you a little bit more information about each of the 8 grantees, 2 of whom you just heard from. But you know, each grantee talks. Each page within the grant directory covers their models that they've used, how they got to it, a bit of the background, and some of the target population. In addition to that, when we actually created this program under FORP, we actually had a care coordination toolkit, the Rural Health. It's popular. It's probably one of the more popular ones on RHI Hub, and we're constantly updating it to make sure it actually is still keeping up with what's going on. As you heard from both of these presenters, care coordination, the name sounds easy, but to actually implement it can be quite difficult to do. And how to do it in a rural setting takes, you know, you really have to think about what that means to the rural setting, whether it's volume that you're dealing with or you're dealing with specific types of population. I'm not going to go through all of them, but the last one I would ask is the Georgia Health Policy Care Coordination Resource Guide. This is coming in as an attachment rather than a link because it's not currently up. But if you're able to look through it, this is through the TA provider for this program, which was the Georgia Health Policy, and they created a Care Coordination Resource Guide to really kind of put in some applicable links to different programs that might be helpful to you if you're starting one, or even how to implement it. If we're able to, we might be able to show some of those resources. If not, again, it is available for download, and it's very short, but it really just hits the point in terms of how, you know, what to think about in terms of care coordination. And that is it in terms of the resources here. We're happy to share any or all of this as we continue, but we want to actually leave some time for question and answer. Next slide, please. These are our contact information. Mine is available. Happy to always talk about my care coordination grantees. Always proud of them. Next slide. And Jack and Marnie's contact information. That being said, I'm going to hand it over to Sunniva and Kate.
Okay, before we get to the questions, I do have a couple more poll questions if we could go through those first, and then we can come back to questions. So I'll pull those up right now.
So while you guys are filling those out, those polling questions out, again, this is Kate, and I'm just going to go through. I know some people had put some comments into the chat box. But I had made an excellent point. Kylie's social service needs community service block grant. And in Wyoming, we have 211 as a resource for all social services. That's great. The social services in small rural communities remains a problem, absolutely. And then Renee noted having that person at the clinic, even trying to find resources, even if not available, is often appreciated by the patients. Yeah, absolutely. And again, yeah, Lynette was bringing out that those were just really excellent outcomes that you saw coming out of these particular programs. So I want to open it up right now to see if anybody has any questions for any of our speakers or anything on this topic in particular. You can use the chat box to post your question, or please press *2. We'd love to hear your voice if you've got a question. *2 to unmute your line, or use that chat box.
Hi, everyone. It's Lynette from the Pennsylvania Office of Rural Health, and I just really wanted to say kudos to your speakers. I really especially liked how they maximized using the multimodal treatment approach. They, included different members of everyone's expertise within their state to help the rural community. So I really was impressed with it. Regarding the Washington State program, I had 2 questions. Number one, I wanted to know if you were able to evaluate the outcomes and how things are going, because it sounds like a really great program. And then you kind of touched on it a little bit, but I wanted to know what the sustainability will be for that program to ensure that people are going to continue to receive that care coordination. I really liked how you did that. So if you could answer those questions, and then I had a question for the other speaker that was immediately following you.
Yes, this is Jack Davies, and in terms of the outcomes, the numbers that we had actually enrolled were fairly small. We did get a carryover request to try to look at and continue trying to enroll people into this year to help us with our actual quantitative analysis on those outcomes. We've got a lot of anecdotal information about the impact this care coordination has had on people's lives, but we're trying to get our numbers up a bit to be able to look at more concrete changes in some of the more typical things like ED utilization and some of those clinical measures. I didn't really address it in my talk, but part of the challenge in that outreach was a couple of factors there. One is we were relying entirely on individuals who were identified through Molina because this was part of this structured health home program. And one of the things we found was that their data was not very good. And so when they would send a list of eligible enrollees to particularly the smaller rural sites, going through the list, they would find that, in fact, most of those enrollees, the addresses were bad or the contact information was bad. So the actual process of reaching out to and enrolling individuals was very time-consuming. In fact, one of the lessons learned was that Molina determined that they had to do that themselves rather than rely on the rural staff that were really pressed for time to do that initial outreach. Then the second piece, I think, you asked was around sustainability. And part of the reason why we wanted to go with this model was because, as I said, it included a payment element. So there's a set formula for how much the care coordinator or the clinical organization will be paid for particular activities. They get a certain amount for enrolling a patient, and then they get a certain per member per month fee for keeping the patients in the program. One of our lessons learned from that was that just one MCO was not going to be sufficient to sustain a care coordinator. The volume of available patients in these very small communities was just not high enough. So that on the good side, this same program is run by other Medicaid managed care organizations so that the care coordinator can conceivably work with patients from multiple MCOs. And now they were starting to also add on for these care coordinators other types of payment sources, including having these same care coordinators do some of the Medicare outreach and some of that Medicare disease management activity. So really what it came down to for sustainability was having to have, you can't rely on one fund source. You have to weave together funds from a variety of sources to support each position in the very small communities.
Okay, great. Thank you so much. Thank you. And then I just have one more question for Marnie. I really liked how you included the certified diabetic educator and a master's level social worker. Those are both really rare to find. So that's wonderful that you were able to utilize them. Now, regarding your program, are you going to be able to sustain that as well? I think these programs are so wonderful, and I'm hoping we can maybe utilize what both of your states are doing here in Pennsylvania. So I just had that question. If you could answer that, that'd be great. Thank you.
Yeah, can you hear me?
Yes, I can.
Okay, I didn't know if I had to hit star 2 again. Thank you for the question. Yeah, you know, we're fortunate that we're within the system, the Avera Health system, that, you know, at the time this grant project started, the coordinated care teams were really taking off. There were only maybe 5 or 6 of them, and at this point in time, it's just grown hugely. It is. We are involved with ACOs, and that does help support the program. But as far as sustainability, you know, we have been able to just roll these concepts and this model of care into the existing coordinated care teams that we have. The other neat thing that happened, you know, initially I had said we partnered with South Dakota Urban Indian Health and Vilas Pharmacy, and South Dakota Urban Indian Health had a CDE and had a pretty clear model of care set. Their CDE throughout the course of our program kind of, changed jobs a couple times, but what happened is within our primary care clinic, we were able to develop our own certified diabetic education program out of our primary care. So while the CDE was doing these visits and educational sessions for the enrollees in our program, our primary care clinics were then developing their own diabetic education divisions, I guess you would say, to be able to carry on the work of the grant program. You know, I'm lucky to have the Vice President of Care Coordination for Avera Health sitting right here next to me, Sandy Crisp, and I'm just going to ask if she might add to that.
Yeah, you know, I think definitely, you know, this concept and the value that coordinated care coordination brings for patients speaks for itself. We have, since the grant ended, we have added across, and we're across, we have a geographical, our health system is in Nebraska, Iowa, Minnesota, and South Dakota. When we started the grant, I think we had 7 RN case managers and maybe 4 social workers and 7 care specialists that were supporting probably 14 clinics, and now we're in 44 clinics. We've got 24 nurses hired. We're up to 13 social workers. I mean, the value of the program, and once the physicians really get a hold of the difference this is making, we're taking the complex patients off from their plate and giving them additional support, which frees them up then to see other patients. You know, so our physicians are happy, the patients are in much better control. You know, they've got improved quality of life. You know, we're a Catholic-based organization, so we're very much mission-driven, and so coordinated care fits directly into our mission. And it is growing by leaps and bounds where, you know, it's hard for us to even keep up to the growth some days. So, yeah, this is definitely something that is growing within our healthcare organization and won't be going away.
Hey, thank you so much for your answer. That's amazing. Great job.
Thank you very much.
Are there any other questions? Lynette, thank you so much for those questions and for the great responses from our speakers as well. Any other questions? Star 2 to unmute your line, or you can always use that chat box as well. So I'm not seeing any other questions pop up, so I just wanted to take the time again quickly to remind everyone that we had sent out the SHIP TA needs assessment earlier today, and we'd really appreciate a quick 5 minutes out of your day to fill in some of that information. Your feedback is really appreciated and very insightful for us to hear back from all of you on what your needs are and how we can improve our assistance for the SHIP coordinators and the state offices. With that being said, again, I want to thank everyone for joining us today, and particularly for our speakers, Marnie and Jack and Soleil, for coming and speaking with us today. And thank you all, and have a great rest of your day.